Okay. Hi, everyone. Thank you so much for coming today. My name is Sue Peshin, and I serve as President and CEO at the Alliance for Aging Research. Thank you for joining us for today's webinar, ICER'S Use of Health Equity, How Changes Are Needed to Support Justice and Prevent Discrimination. This afternoon, we're going to take a look at how health equity considerations are currently being utilized or not utilized in the value assessment space. For those who may have never heard of them, the Institute for Clinical and Economic Review, also known as ICER for short, is a non-governmental organization that issues cost-effectiveness reports on new medical treatments. Health insurance companies use ICER reports to help decide whether to cover the new treatments. And when a company does offer coverage, ICER also offers whether or not there ought to be certain access barriers put in place to help control overall costs for the new therapy. Today, we're here to discuss the findings and recommendations from two recent reports. The first is aligning health technology assessment with efforts to advance health equity, which was jointly created by the National Minority Quality Forum, Global Liver Institute, the Preparedness and Treatment Equity Coalition, and the Partnership to Improve Patient Care. The second report we're going to be discussing today is the Alliance's report, ICER Reviews and the Aging Population, a review of recent ICER reports and recommendations to advance aging equity and value assessment. We wanted to showcase these two reports because the use of value assessment in the United States is growing, and the negative implications for patients and people with disabilities on access to care are significant. I already mentioned how private insurers use ICER analyses. For government insurers, ICER analyses are used to set formularies by the Veterans Administration. There's a growing reliance on ICER by state Medicaid drug affordability boards that can consider cost-effectiveness analyses. And there have been both legislative and regulatory proposals over the last 5 years that would explicitly or implicitly either hire ICER as a health technology assessment body or adopt ICER'S methodology in price setting of prescription drugs. Last August, the Inflation Reduction Act was passed into law by Congress, and it included direct negotiation provisions, but it left the door open to how CMS will implement direct negotiation. And ICER's at the front of the line on this, ready and available, and we're concerned about that. So today's discussion of value assessment and equity comes at an important time. And recently, ICER announced that they're doing a self-analysis of how equity considerations are utilized in their reports, and a readout's expected this spring. So the two reports our panelists are discussing today include recommendations for policymakers and health technology assessment developers, including ICER, in their future model development. We know some folks from ICER have joined us today. We want to thank you for coming to listen, and welcome. Now I'd like to introduce our three panelists. Okay. Let's see if that works. Nope. I'm trying to switch slides. Okay. Gretchen Wortman is Vice President for Policy and Program at the National Minority Quality Forum and Director of the NMQF Institute for Equity and Health Policy and Practice. Gretchen also directs the NMQF National Alliance for Brain Health and Awareness. Gretchen has more than 40 years of experience in the public and private sectors in health policy strategy and analysis, issue advocacy, and program administration. And prior to her tenure at NMQF, Ms. Wortman held positions with the Missouri Department of Health and Senior Services, and she currently serves as a peer reviewer for the Journal of Healthcare Science and the Humanities. Thank you for being here, Gretchen. Kirsten Axelsen is a founder and executive secretary of the Preparedness and Treatment Equity Coalition, known as PTEC for short, which we are a part of. And it's an organization focused on identifying metrics and reimbursement pathways to achieve greater equity in healthcare. Kirsten was previously on the leadership team of Pfizer's global innovative pharmaceutical business, where she led strategy and business evaluation. And previously, Kirsten also led Pfizer's global policy team, where she built a team dedicated to policy impact analytics. She's currently a visiting scholar with the American Enterprise Institute, an Aspen Institute Health Innovator Fellow, and a consultant to life sciences companies. And Adina Lasser is the public policy manager at the Alliance for Aging Research. Adina joined us at the Alliance in 2022 after previously working at the American Urological Association and CRD Associates. Her background is in health policy, patient advocacy, lobbying, and health economics. Adina holds a BS in economics from the University of South Carolina and runs the Alliance's project and programming on ICER. She's the lead author of the Alliance's recent report on aging equity. Some very quick logistics first. We're recording today's webinar and we're going to make it available. And second, each panelist is first going to go through their remarks, and then I have some prepared questions for them. We will have some time at the end for audience questions. And if you have a question at that time, please raise your virtual hand and I'll call on folks and we're going to give you an opportunity to come off mute and ask your question. Okay, Kirsten, I'm going to turn it over to you.
Thank you so much for the introduction, Sue, and thanks to everybody for joining today. Pleased to be with you, and I think as Sue is getting up my slides, I'll just talk through my first slide, which, as Sue mentioned, that I've worked for a long time in biopharma as an advisor to biopharma companies and working in biopharma companies. So that is both my experience, and it's also, of course, a bias that I bring to the table. My focus has been on payment policy, incentives, the use of real-world evidence and clinical trial representation. I'm here today with many hats, but one of them is as the founder of the Preparedness and Treatment Equity Coalition. We identify ways that health systems around the U.S. are reaching people who typically get less than average health outcomes in the U.S. healthcare system, and providing the funding and helping to create partnerships that will evaluate those approaches so that they can be scaled up if they are effective. Next slide, please. So, one of the things I just sort of set up is my view on what is good value assessment. And this is in any organization that is doing it. Plenty of countries around the world do value assessment. And then, of course, the health plans in the United States do value assessment, states do value assessment, organizations like ICER and others and academic centers also do it. So quite simply, good value assessment is able to measure value of an intervention, monetize that value consistently. So what is that value worth? And then, if you can do those things right, that turns into a price. Which is incredibly straightforward in concept, but incredibly hard to do. And I guess the thing that I'll kind of emphasize consistently throughout my remarks is the perfect, most educated value assessor will have created an estimate. We do 2 trials even to get a drug approved. And if those 2 trials say different things, we have an issue. So I think as we think about value assessment, I think about that there should be multiple value assessors looking at different types of data, different patient populations. In fact, that is what the health insurers do, right? They evaluate the data on their population. They evaluate how the therapeutics are working over time. And to me, supporting that kind of a system that is decentralized. And if I were to identify a perfect role for government or non-governmental organizations, it would be to put more of those types of assessments out there that are tailored to different types of patients, different parts of the country, people with differing levels of access to care. Not everybody gets to go see a specialist, so they may not have the same outcome from their cancer treatment, and making that available so that we can see the range of value assessments and really moving away from this idea that there is one right price, because there may be no price at which a drug is worth it to a certain health plan, or there may be a price and they negotiate for that price and get a big discount and make that drug available. But we are all different people with different healthcare needs across the country. The data that we're using to do these assessments is based on clinical trial data, insurance claims, health records, surveys, registries, and I know increasingly patients and patient experience. There's also, multiple consumers in healthcare, unlike probably any other commodity. So when we talk about measuring value, the value to whom, monetize that value, well, whose money and who are we monetizing the value for, and what are the budget constraints. So all of those things come into play, which may skew the value assessed and how that translates into price depending on your point of view. You can go on the next slide. So, part of why value assessment is always an estimate is that data is limited to certain experiences and certain people. Again, that's why I'd advocate for multiple assessments, considering data from different patient populations, different experiences, different comorbidities, and also over the lifetime of the drug. Averages leave people out. If we sized all pants to the average person, those pants would fit almost nobody. And so thinking that we can size the price of the drug to the country, I think, is a fallacy. Again, health plans, the big health plans have the leverage when there are therapeutic alternatives to ask for the discounts. Again, I think where there is a real role for private and public industry is to help create this information for the health plans that don't have that same kind of leverage, who would be able to use that tailored value assessment, range of value assessments for their population. And then, we all have different endpoints that we're considering. The right price for a policymaker where drug price controls poll very, very favorably is the low price. The right price for an investor considering putting money into the next treatment is a higher price. Neither one of those prices are right. And the right price is, again, somewhere reflects, I would say, the patient experience, as well as what can be afforded. Let's see, we'll go to the next slide, please. And just as a quick illustration of the limitations in data, this is an assessment of the representation in clinical trials. Just a bit of a progress check. This is using the FDA drug approvals database. If we consider just thinking about our clinical trials enrolling a percentage of people that just reflect the US population, not even the epidemiology of the disease. Of the 53 new drug approvals in 2020, 6 included Blacks and Latinos in proportion to their representation in the US population. For oncology drugs, 0. And then you can see those numbers for other years. So we do not have clinical trial data that represents the country. And then, as we really consider where things are evolving, the recent developments, including the Inflation Reduction Act, the use of coverage with evidence development in Medicare to limit access to medication, class of medications, and then increasingly state drug review boards have some with the ability to either recommend or set prices. Just shows there's interest and also opportunity for more value assessment in the US. And then on the private sector, we have seen slow but growing interest in connecting value to price, including through contracting such as value-based payment agreements. And what I hope this panel will discuss is how is evidence used to set price in the US and how should it be used? And depending on how it's used, what does that mean for investment in clinical development and investment in certain types of drugs for certain types of people? I think we've got one last slide, maybe. I think we can skip past this one. Sorry, Sue. Thinking about how these types of these 3 policies I mentioned that can rely on evidence to inform price. Outside organizations can be called on to inform. I would argue there should be more outside organizations. This is an opportunity to fund, in particular, I think, universities that have diverse student populations, health centers that are in communities where they might not typically have the analytics practice, to evaluate how drugs are working, particularly in people who are getting less than the full benefit from the healthcare system. It'd be great to see more of those being considered as we decide what value is. And ideally seeing, I think, CMS as an arbiter of multiple value assessments would be a really great public good. And then others could also bear witness to what other organizations are evaluating the medications are worth. And then next slide. So a few points I hope we talk about is who's left out by an average. What's the value of real world evidence versus clinical data? What these types of value assessments mean for investment in new drugs, and does it matter? And then, we all bring a bias. So what is the bias that the value assessors are bringing to the table? Even the most unbiased organization has an agenda. And again, I include myself in that. So what is the role for getting multiple viewpoints so that both the biases and the different approaches can be considered? And I got one last slide. Oh, no, I'm done. Thank you.
Thank you, Kirsten. Okay, happy to have Gretchen go next.
Thank you, Sue, and good afternoon. My name is Gretchen Wortman. I'm Vice President for Policy and Program of the National Minority Quality Forum and Director of our Institute for Equity in Health Policy and Practice. I'm honored, truly, that the Alliance for Aging Research has afforded me this opportunity to share NMQF's perspective on the potential for synergy between the health technology assessment process and the health equity movement in the United States. I would also like to take a moment to thank Sarah von Gertruden and the Partnership to Improve Patient Care for their commitment over the years to enabling NMQF to work closely with them and other patient advocacy groups to highlight inequities among patients and families with disabilities. For those who don't know us, the National Minority Quality Forum is a 501c3 not-for-profit research and education organization based in Washington, D.C. The mission of the forum is to reduce patient risk by assuring optimal care for all. Through our Institute for Equity in Health Policy and Practice, which is the central operational arm of NMQF policy, NMQF identifies imperatives and opportunities that facilitate the exchange of information, support educational efforts, and enable engagement in consensus-building initiatives that focus on forward-looking policy. Next slide, please. Next slide. Again, and let's get one more slide. Okay. The challenge that we're discussing today, but is of longstanding in our country, is that when NMQF is confronted in all of our initiatives, what we face is that the current research delivery and financing system construct often serves to increase patient risk in service to financial risk mitigation and to assign differential value to different population and patient cohorts. I think it's safe to say that efforts to reform the current system to redress inequalities, disparities, and inequities have been ineffective. And that is perhaps where discontent in the moment is offset by anxieties regarding the unknown. Unfortunately, what appears to have been very effective is policies and practices that serve to pathologize the behavior and the lived experience of those whose health is compromised and whose lives are foreshortened by structural and systemic failure. In the interest of time, I'll state my take-home message here, which is that value assessment has the potential to work to the benefit of systemic health equity. Our 4 organizations have authored a report that contains recommendations, encouragements, and carefully worded advice. The report was created to inform the perspectives of all sectors and entities who may have some concerns that value assessment, health technology assessment, will continue to be heavily weighted toward mitigation of financial risk and not assign the highest priority to improving the quality of life of the individual patient, that which is indeed the experience of us all. It is, we are concerned, possible for value assessment to be successful according to the metrics it favors yet there be no measurable change in patient care or outcomes at the individual, family, or community levels. The National Minority Quality Forum believes that the American Health Services research delivery and financing system is in the throes of a crisis that cannot be repaired absent a re-envisioning and a rewriting of the source code that governs its processes. Equity-centric value assessment, which is an inflection point, not an endpoint, requires intentional equity for all population and patient cohorts throughout the American research delivery and financing system. We must design and operationalize a research delivery and financing system that neither creates, enables, or tolerates biases in inputs or outcomes. And that, I suggest to you, is the real challenge. Not what ICER or IVI or CMS or CDC or commercial payers do, but what those in their authorizing environments decide to do. It also requires proactive, anticipatory, and empowered engagement from the patient advocacy community. In closing, the National Minority Quality Forum believes that it is possible for the market objectives of commercial interests to coexist with and support the principles of equity and mitigation of patient risk. We also believe that given projected changes in the size and demographics of our population, operationalizing the principles of equity and social justice has the potential to significantly enhance the return on investment of all sectors. And that is why NMQF is here. I look forward to answering any questions you may pose and to seek opportunities to work with you all. Thank you, Sue. And I think I turn it over to Adina now.
Yes, hi everyone. Good afternoon. Thank you so much. I want to echo Sue's sentiments and just thank both of my fellow panelists for being here today. It's definitely an honor to present with the both of you. Today, I'll be talking about the report that the Alliance recently authored on ICER'S treatments of older adults in their analyses over the last couple of years. So my section is gonna just take a little bit of a narrower focus than my fellow panelists. So I'll focus on why we felt now was the time to write the report, major themes and issues that emerged from that analysis, and then finally some recommendations for improvement. So as Sue mentioned briefly in her remarks, in 2022, ICER received, ICER, or the Institute for Clinical and Economic Review, I'm not sure who said the name all the way, received a grant from the Commonwealth Fund to evaluate methodological changes they could make to better support their health equity goals. And we commend the goal of further incorporating health equity into their cost effectiveness analysis. But in that press release that they did, we noticed that they did not mention anything about persons with a disability or older adults. So it's important to us to do the work of evaluating how those groups are treated in ICER'S existing reports so that we can see if their new health equity measures, which they'll announce in March, actually address the existing issues for those populations. Next slide, Sue. A major theme that emerged in this analysis is that ICER'S contextual considerations just don't make it into their final quantitative analysis. And contextual considerations are those factors that matter to patients, but are not captured in any data that the group is using. ICER considers health equity to be a contextual consideration. And so there's a lot of content about health equity in their reports, but because it's hard to quantify, it doesn't actually get into their final numbers. And ICER is full of health economists, and so they hold quantitative analysis in high esteem. And when health equity is relegated to that contextual consideration, the actual numbers that ICER places so much value on don't reflect actual societal impact. And not only does it show up inconsistently in their quantitative analysis, there's actually no real framework that ICER uses to incorporate the societal impact into their guidance to policymakers, manufacturers, or payers, meaning that the level of consideration underserved populations receive in those final recommendations is ultimately pretty inconsistent. Next slide, Sue. Another significant limitation that we saw, which is also something that Kirsten mentioned, is that ICER relies on clinical trial data. But as we well know, clinical trials struggle to recruit a diverse study population. And so this is especially prevalent when it comes to older adults, because they're often excluded from clinical trials because of things like comorbidities, underinsurance, transportation issues, communication issues. And so that's something that we felt it was important to address. And ICER is aware of that. And according to their value assessment framework, does try to incorporate real world data where possible. But real world data is often messy and imperfect, and it's certainly not randomized like you get in a controlled clinical trial. And so it doesn't meet that gold standard of clinical trial data. ICER will note that the clinical trial data, ICER will note that the clinical trial data doesn't capture every patient, but they use it anyway. And so this has the actual impact of kicking the can down the road and telling other stakeholders if they need to solve the data issues, it's not ICER's responsibility. But we believe it is their responsibility to make sure that their recommendations are accurate and inclusive, and that's impossible to do if they have incomplete data. All right, next slide, Sue. I'll talk about this quickly, but I just wanted to go over a major facet of ICER'S analyses, which is the quality adjusted life year, or known as the QALY for short. And it's a health economics measure that represents the degree to which a drug or treatment extends or improves quality of life. And that's on a scale from 0, which means dead essentially, to perfect health, to 1, which means perfect health. And the QALY is calculated with an equation that I don't have in front of me, but I believe is extended quality of life times extended life in general. And to correct me if I get that wrong. But because of that, the actual impact of the QALY is really big. So the chart here is a really good illustration as to why health state preference values are based on the perceived value of living the condition in comparison to being in perfect health. And so if a treatment is for a group that is sicker or older, or it's focused on a population that has historically faced inequities in a society and the healthcare system, the treatment is assessed as being less valuable, meaning that those groups are considered more expensive to treat. Next slide. So in our paper, we made 5 recommendations for how we thought best to fill in the holes that we found with ICER'S research into older adults. And so this is the first one, and the Alliance is hopeful about the fact that ICER is doing work to make changes to their methodology to make it more inclusive. Because of the concerns that we've raised over the last several years, we're anticipating and hoping for big changes. But it's our understanding that that work is solely focused on aspects of equity having to do with race and ethnicity. And we hope that ICER will expand that work to be more inclusive of all underserved communities. Next slide. Because of ICER's focus on evaluating drugs before they come to market, it's much harder for them to incorporate any real-world data. So if ICER allowed for a follow-up post-market analysis, they'd be able to be much more inclusive in their findings. So our second recommendation is that they do this sort of follow-up on subgroups of interest. This next slide focuses on data concerns that I mentioned earlier, so I'll skip it. Next. For this one, we hope that ICER will consider their use of the QALY as the National Council on Disability, which is a government agency, as well as patient advocacy organizations and medical ethicists have raised concerns about the discriminatory impacts that are caused by the QALY. And then last slide, Sue. And our last recommendation is that ICER creates an ombudsman. We recommend that ICER has an independent ombudsman to analyze commonly raised concerns, as well as provide recommendations and just generally support accountability. So that's my slides.
All right, thank you so much. That was terrific. I am going to pin all of you so that we can now ask some questions. And I promise I'm going to take a 101 advancing slides class after this. But I have a couple of questions. Let me stop share so I can see folks. And we'll see if anybody, we don't have any questions yet. So my first question is for Kirsten. And it's around sustainability of the Medicare program, which has been getting a lot of attention in both political and advocacy circles. There seems to be a growing interest to reduce overall costs in the Medicare and Medicaid programs by applying traditional value assessment, but this is going to have implications for patient access. And at the same period of time, you have this big population growth, right, especially among older adults. So how might health advocacy organizations be thinking about the intersection of access and value assessment in Medicare direct negotiation implementation?
Thank you. I guess I'll start with the last part of your question was, thinking about the direct negotiation. By definition, the way it's being approached is not really value assessment. It's choosing the biggest drugs in Medicare and saying we're going to set the price for those. There's a ceiling which may already be below what independent value assessors or government value assessors might say the drug is worth. And also if that drug is already being rebated at a level that is making it lower costs to health plans that are able to secure that rebate, that becomes your new ceiling. I would rather see an assessment of where money is being wasted, not just focused, and I realize you focus on the biggest drugs, you get the biggest savings, but you don't necessarily get the biggest benefit to patients. And it's kind of really reflecting on the remarks that Gretchen made. That's risk mitigation for budget holders, not risk mitigation for patients. So I would say I would rather see the focus be on lower value medicines or lower value uses of medicines, such as medicines not being picked up or adherence issues. And also more assessments of the kinds of side effects that really affect quality of life that aren't included in sort of traditional value assessments that are driving up system costs, both in and outside of the drug part of the benefit.
Thank you, Kirsten. Okay, next question for Gretchen. What should meaningful engagement of diverse stakeholders in the patient and disability communities look like when it comes to creating new models for value assessment?
I would say that for organized patient advocacy, health consumer advocacy, what is most meaningful is creating the capacity within your organizations to think through the lens of value assessment before ICER issues an announcement about a particular therapy. Because just as we're asking, we're creating an expectation of ICER and other technology assessment organizations to think about the patient more so than about the financial risk mitigation, we also need to create capacity within that particular stakeholder sector, which is, in our view, in NMQS view, the final metric, the most important stakeholder sector. The patient advocacy world needs to have capacity to factor in, my language, the threat of value assessment long before their particular therapeutic area scrolls up within any of the health technology assessment organizations. Now, that's a heavy lift, but I would submit it's a much heavier lift when you're faced with a diagnosis and you can't access the therapy, or because of the down the road sort of the pull through, which is our concern, a significant concern of ours, from these value assessment processes, the process of developing new knowledge, of innovating and developing new knowledge has been compromised long before your particular need surfaces. So I guess I'm saying, sorry, it's a long answer. I'm not looking necessarily for ICER to serve a patient engagement, to address a patient engagement function. I think it would be great if they do, but that the patient advocacy world recognizes the importance of doing so, so that the baseline knowledge is available to the system as therapies move through FDA, as they encounter value assessment processes, and then they become part of the tools that clinicians have to offer. And I'm going to say one more thing, so excuse me. Value assessment is much more inclusive than what the ICER'S and IVIs of the world do. The work that is done, the calculations within CMS, when national coverage determinations are made, those are value assessments. When the immunization advisory committee, and that's not the correct name of it, at CDC, develop its recommendations regarding the availability of vaccines, that's a value assessment. When Medicaid decides whether to add a new therapy to this formulary, that's a value assessment. So also, I think the understanding of the pervasive nature of these value assessments needs to be embraced by the patient advocacy community. So thanks for your patience.
Yeah, that was a really important comment at the end. And you're talking about the CDC's ACIP, the Advisory Committee on Immunization Practices, and they are allowed as a part of their charter to consider cost effectiveness for sure. And they have those presentations. We're starting to get some questions, which are awesome. I'm going to ask Adina a question though about ICER'S EVLYG alternative measure to the QALY. And that because the reason why I want to ask you is it's getting a bit of attention in the press around the recent Alzheimer's report. My understanding is it still favors treatments with greater life extension, which puts older people and people with diseases where treatments primarily improve quality of life, like depression or migraine, at a bit of a disadvantage. So should reporters be buying into ICER'S use of the EVLYG? And what is that? What does it stand for? It's like upper and lowercase letters. Tell us about
Yeah. So the EVLYG stands for Equal Value Life Years Gained. And I think that it is ICER'S attempt to take some of the heat off of themselves when it comes to all of the criticism that we've given about the QALY. Unfortunately, it doesn't actually accomplish that goal. And so essentially, advocates have been complaining that the QALY measures quality of life, but quality to who? And so the EVLYG kind of takes away that measurement and just says, okay, generally, how long does it extend life? And it looks only at extension of life and not quality of life. By doing that, it puts life gains at a static number. So it's around 0.85 as opposed to using the health preference state values that are used in a QALY. And those vary by condition. So it still favors treatments, like you said, with greater life extension and where the quality of life of surviving patients is low. And it knocks treatments where quality of life is improved, things like, but extension of life isn't really affected, like depression. And so it sort of sets a benchmark of the QALY while still allowing for ICER to conduct the kind of cost effectiveness analysis that advocates like us find objectionable. And so in my opinion, it's a little bit of a posturing to the problem without addressing the actual root of the concern.
Terrific, thank you. So Candace put a question in that is very similar to what my next question was going to be. So I'm going to use her question. Are there value models that do a better job in factoring in aspects of value that ICER considers contextual? So, you know, and I'll just broaden that to say, are there any particular frameworks right now that interest you in particular, and do they address any of the problems that we brought up here? And anybody can answer that. Kirsten, you want to start?
Yeah, I'll start. I think the limitation in most value assessments is it boils down to one number. And that really disregards that different people have different needs. You know, just to kind of continue with this analogy, if I am designing a formulary for an employee group, I'm an employer, you know, designing what drugs I'm going to cover, and I have employees who work, their work requires labor, their work requires being able to be alert. You're going to think about things like fatigue related side effects. If I'm somebody making a decision about my cancer treatment, it may be that the drug with the longest survival is important to me, or it may be the one that has the least ER visits related to nausea is the most important thing to me. So what I would rather see, and I think there is a huge benefit to this, is value assessments that consider various things that matter to people. The primary endpoint of the drug matters, but what are the other things that enable you to do your work, do your life, be a caregiver? And then I think we don't give people enough credit. They know what their quality of life is worth. And giving as much information to the people who are purchasing benefits on their behalf, who might be able to take that variety of perspectives into place and design a benefit that meets that population if they care. And that's the other thing I think to think about with value assessment and the biases we bring. Again, that's why I would promote there should be multiple value assessments, because I think people who are choosing health benefit designs should have the benefit of seeing multiple assessments and then being able to reflect those different biases in their decision making.
Anyone else comment on that? Go ahead.
Yeah, I'll go next. I'll talk a little bit about a couple of specific ones, because I completely agree with you, Kirsten, that I think there's just not one answer to this. But there are a couple of groups that are working on some really interesting pushes for it. The most recent one that I've seen that I think is really fascinating, that I haven't seen talked about much, is research that comes from Cornell that was published in 2022 in the Journal of Health Economics. And they try to account for differences in patient preferences, which, like we've been saying, is one of the major concerns when it comes to how averaging metrics are used now. And they actually found that when they did that, efficacy gains from newer drugs didn't justify high prices for the population on average, but they were justified for those sicker late stage cancer patients. And so I think that's some really innovative research that people should take a look at. And then PCORI and ICER'S are both always doing some interesting work in this space. ICER'S, specifically the value flower, I think is worth looking at.
Yeah, I think what I would add to the answers, I think it's additive, is, well, first of all, I haven't done an exhaustive study of value assessment models. A concern I have is that I'm hearing from Kirsten that maybe we need more. Not one good one, but I would say, again, from the National Minority Quality Forum's perspective, the question we're constantly asking is why? Why are we conducting value assessments, which, if you, according to Kirsten and Adina, and I think Kirsten's telling the truth, we're not talking about value, we're talking about price. Okay. And that's a legitimate exercise for those who pay to undertake. But it's not the value of the therapy. And the concern that we have is that that price that's being said is not just on the therapy, but it's on that human being, it's on that life, it's on that community. And so by extension, we're assigning differential value according to some really complicated, complex health economics algorithms. You're assigning a differential value, quantitative value on the life of human beings. And that's unacceptable regardless of the model. And so if payers and others have a need to manage their budgets by making a determination regarding how much they want to pay or are willing to pay, I'm not questioning their right or maybe their obligation to do that for purposes of their stakeholders, but we're merging that conversation with a conversation about the value of human beings. Qualities do that in a disturbing, but actually very open way. It's terrifying, actually, how blatant a devaluing and the manner in which they're devaluing lives using qualities or their EVLYGs. So I would say NMQF would say that there is no acceptable approach to value assessment, because in concept, if you're including those human beings and the vulnerabilities they bring to their engagement with the care delivery system, which is why it's there, which is there to mitigate their risk for the disease or consequences of the disease, then we've got a problem as a society. And by a society, I mean a global society, not just what's happening in the United States. I understand that other countries do this as well, but that doesn't mean it's a right thing to do. And so I would be very cautious about trying to identify a value assessment model that really is not assigning value to the patients. And I will say that I've worked with IVI on certain committees, and I've been very open about these, about this perspective. So I'm not talking out of school. And we have communicated same over the years to ICER, and we'll continue to do so. Thank you.
Thank you, Gretchen. I do have to say, I've in different venues, I have used the analogy of, you know, when you get almost any other consumer product, the consumer is not sort of sized up in relation to that product. If you want to buy a car, for example, they don't look at you and say, oh, you've got a bum knee, you're not going to drive the car as long, so we're going to price the car differently. So I completely agree with what you're saying, that we all ought to be questioning the paradigm of why are we sized up in relation to the healthcare that we need. We are purchasing health insurance to be there when we need it. And looking at the value of the medical services and products that are afforded to us is one thing, but including us in that calculation is a different thing altogether. And that is the root of what we're talking about here. I wanted to just give Eugenia Brooks the last word. I liked your comment, Eugenia. I don't know if you're still with us, but I can read it if you're not. Eugenia participated with, oh, okay, hi. You participated with us in our Talk Nerdy program, and I would love for you to read your comment, and then we can wrap up. Oh, wait, I'm going to ask you to unmute.
I just pointed out the fact that the quality of life healthcare is not a luxury, and they need to stop looking at it as such. We're not talking about floor mats for a Corvette, okay? We're talking about people's quality of life healthcare. So if it costs you $5 to make the damn bottle, then you don't need any more than $35 or $40 to run your business and turn a profit. So stop looking at me and telling me that I need to come up with hundreds of thousands of dollars for something that costs less than 100 in total. And we need to stop, and I mean everyone, whether you made big money in your life or not. I personally was a social worker, so no, I didn't make big money, but it shouldn't make a difference. If I was freaking Bezos over at Amazon, what difference does it make? It costs what it costs, and your profit with it is that. You don't need to have all this extra, and it is unconscionable that people just sit back and act like, well, you know, they got to turn a profit. Really? 1,000% profit? Are you kidding me?
Okay. All right. Well, thank you. I'm really appreciative of your comment, Eugenia, and I'm very appreciative of everyone who's here. I know there are other folks who look like they're interested, but we have to go. Thank you so much for joining us today. Thank you to the speakers. And I hope everybody has a great rest of your afternoon. We are taping this, so we'll make it available for distribution. Thanks so much. Have a great afternoon. Bye.
Bye-bye.
Thanks, everyone.
I'm so sick of all of it.